Welcome to the United Leukodystrophy presents Hypoventilation with Dr. Demirel from Mayo Clinic.
Hi, everybody. I'm sorry, first of all, about the title changes. I wasn't aware of the previous one. My name is Nadir Demirel. I'm one of the pediatric pulmonologists here at Mayo Clinic in Rochester, Minnesota. The title of my talk is Hypoventilation, and more broadly, respiratory problems in genetic disorders and neuromuscular disorders. They have a lot of common problems. And I am not going to talk about practical part, and I'm more interested to talk about concepts. I want you to understand how we think about respiratory problem in your child. So the objectives is the definition of hypoventilation, what it is, how we detect hypoventilation, and when we detect it, how we treat, and when we treat, and after we start to treat, how we monitor the treatment. So when I Google hypoventilation, actually I Googled ventilation, and it gave me this image. Uh, Actually, it's very accurate. You see that this window is open and the air comes in and comes out. Basically, ventilation is that the air enters in a closed space and comes out. It is exactly what it means in human beings. We take a breath, the breath comes into our lungs, and we exhale it out. If this door is a little bit open, it will leak a little bit here, and this is what we call leaking in mechanical ventilation, and it's exactly how it looks like here. So in human being, obviously the air enters through the nose or mouth, goes down to your large airway, which is called trachea, and you see that it's covered with cartilages. It's a kind of a hard tube. Particularly the front part is covered with cartilages. The posterior part is muscle, and it goes into the lungs and small airways. You see here your diaphragm and obviously chest muscles covering the chest wall. So when the air moves into our lungs, it's an effort not of the lungs, it's an effort mainly of the diaphragm. So the diaphragm contracts, and normal situation is this, and when it contracts it goes down, and the chest wall raised with the muscles covering between your ribs, and uh, the volume of the chest increase, which sucks the air in. So this creates a negative pressure in the lungs that sucks the air in. When you exhale, on the other hand, it's more of a passive movement. So the muscle relax and the air goes out, and the muscle goes back to its previous state at the beginning of inspiration. So the inspiration is a forceful, muscle related, mostly diaphragm related uh, action, and expiration is more passive action. When you think about expiration, if you have any obstruction in your upper airway, any obstruction in your lower side of the airway, larger airways, or even in the smallest airways, this obstruction will make your expiration harder. So the air has hard time to go out. So then you start to use your accessory muscles and expiratory muscles again inside of your ribs. There are muscles specifically used in this kind of situations. So let me go again to the smaller units. So the smallest unit of the lung is an alveoli. It looks like a balloon. When you take a breath in, the air enters your alveoli and the oxygen cross the wall between your alveoli and the blood vessels and join your uh, arterial blood, which is an oxygenated blood. And the uh, oxygenated blood goes to your left heart, and from there goes to your body. In the cellular level, the cell needs energy, right? It burns the energy with oxygen, and the end product is carbon dioxide. And the carbon dioxide join the blood vessel on the venous side and now goes to the right heart with much less pressure. And from the right heart, it goes to the lung again to give up the carbon dioxide and get the oxygen in. So the exhalation is to get rid of carbon dioxide. The inhalation is more to gain oxygen to the bloodstream. This is simplistic presentation, but it's very true. And we always think about this graph every time when we have a patient with respiratory disease. So basically, what is hypoventilation? As I said, there's certain amount of air that we need to get in and out every time. And when you think about time component of it, in 1 minute, there is certain amount of air that needs to enter our lungs and leave our lungs, enable to clear carbon dioxide and get enough oxygen. So if this amount, total amount of air entering our lungs and leaving our lungs is less than it should be, it's called hypoventilation. So there is a balance in our body. So there are three components of it. This is a very important graph that summarize that I took from a French publication uh, published recently, a couple of years ago. Basically, there is the respiratory muscle capacity. As I mentioned in my earliest slide, the diaphragm is the major player there, but also chest wall muscles are important players. So everybody has a respiratory muscle capacity, right? You cannot run forever. So if your respiratory muscle capacity is lower than it should be, this may be related to an underlying genetic disorder. This may be related to an underlying muscle disorder. So then this balance will go up. The other one is central ventricular ventilatory drive. It's in our brain. There's a respiratory center. And this center is sending messages to our respiratory muscles to start a breathing. If it doesn't send a message, it doesn't give any breath. So there is a genetic disorder, for example, that this center is not sending these messages. So the child has a totally normal lung and the child has totally normal respiratory muscles, but the child doesn't take a breath. And this central ventilatory drive is balanced with sensors in our body that measures the oxygen level and the carbon dioxide level in our blood all the time. Like someone who is checking their blood sugar, these sensors are checking this two gas concentration. And if the oxygen goes down or the carbon dioxide goes up, it sends extra stimulus to the respiratory muscles. And the third one is respiratory load. So basically, our airway by nature has some resistance, right? When you take a breath, like any tube, the wall of the tube cause some resistance. And and the respiratory load obviously increase, for example, if you have a respiratory infection. So if you have any kind of infection, it may be an upper respiratory infection, it may be a lower respiratory infection like bronchiolitis, pneumonia, your airway will be narrower because of the swelling inside your airway. So this will make the movement of air in and out more difficult. So uh, these three mechanisms work in balance. When one of them is not functioning well, the other ones try to compensate that. For example, if you have a respiratory infection, in a normal individual, your central drive will send more messages. So your muscles are going to work more to move enough air that you don't have low oxygen level in your blood or high carbon dioxide level in your blood. If your muscles are weak, though, your reserves are much lower. So then, when you have an infection, you are in more trouble. Then you may develop hypoventilation. So I want to talk from a couple of more problems related to respiratory load. These are common problems that we see in genetic disorders like leukodystrophy. One of them is aspiration syndromes. So think about part of your nutrients that should be in your stomach enters your airway and goes down into your airway. So these nutrients rich elements may come from when you are swallowing your food or liquid, or they may come from your stomach with a reflux coming up, or they may come from your mouth from the saliva secretion. And obviously everybody has uh, multiple bacteria in their mouth, most likely anaerobic bacteria in their mouth. So with saliva, this bacteria goes down to the airway. Now in your airway there is a not an acute infection but a chronic inflammation. When there are multiple bacteria sitting is in this high nutrient rich environment, they cause more and more inflammation, and I can call it chronic infection. Even though you don't have fever, it's just a chronic infection sitting there and causing a lot of inflammation. This will in the long term increase your respiratory load. Let me add one more layer on top of that. So you are aspirating slowly very small amount of nutrients, and they are not going every part in your lungs. They are going to some part of your lungs. One day they can go to the right side, another day they can go to the left side, or they can go always to the right side or one part of the right side. So now our lungs are designed to be very homogeneous. Now you have a very heterogeneous environment. There are some part of your lungs that has more inflammation and swelling inside and infection than other parts of your lungs. And in the long term, this inflammation may make your lungs much stiffer than the other parts. So when you take a breath, obviously the air is not going to the every part of your lungs symmetrically. It will go to the part of lungs that has less resistance and less inflammation. Now this part will get more air and the other part will get less air, and in the long term they will collapse. The small alveoli will collapse, and it will even cause more resistance there, that it will be very heterogeneous. Now the blood is going both sides the same amount but doesn't get enough oxygen, and it's not just not moving enough air in and out, but it gets much more complicated with addition of something like a chronic aspiration syndrome. So I hope all this makes sense, because I think it's important for you to understand how we think about your child's respiratory problems. And this may sound theoretical, but uh, this is how we think. And these are very important concepts that we all need to understand well in order to solve problems, because the problem can be multiple and you need to address the right problem. So the result of this hypoventilation is increase in carbon dioxide in your blood, which is called hypercarbia, and decrease in the amount of oxygen in your blood, which is called hypoxemia. So having hypercarbia and hypoxemia has clinical implications. So this table is a little bit long. I'm not going to tackle every one of them, but I think it's important to understand when someone starts to develop hypoventilation, which goes very slowly though. It's not an acute problem. Most of the time, it's a very slow progressing problem. So you start to develop these symptoms that you and your doctor may or may not suspect. One of them is fatigue. So fatigue is very related with high carbon dioxide, morning headaches and continuous headaches during the day. Again, high carbon dioxide. Dyspnea, meaning uh, increased work of breathing, is more related with low oxygenation. Awakenings with dyspnea during sleep, difficulty concentration, decreased intellectual capacity, having hard time at school, um, having some uh, uh, irritability and anxiety, even some mood problems. Um, Depression, again, is related with high CO2 carbon dioxide level. Obviously, having obesity on top of this may also add another layer of obstruction to the upper airway, and also will affect your chest movements as well. So I think it's important to watch these symptoms, particularly fatigue, uh, and sleepiness during the day, taking naps, uh, having headache in the morning and during the day. These are important findings pointing hypoventilation. So how am I going to detect and diagnose hypoventilation? So I know that the carbon dioxide may start to go up and my oxygen may start to go down. And I may or may not have some clinical symptoms, but clinical symptoms are very important to watch, because when they start, we for sure start treating patients. And what kind of tools do we use to detect hypoventilations, to measure oxygen level, carbon dioxide level in the blood? And what are the guidelines that tells us uh, how to detect and when to start to treat? So these are the tools that we use in the clinical setting to diagnose hypoventilation. The first one is overnight oximetry. Obviously, someone who develop hypoventilation, this starts at night, because we all sleep with relaxed muscles. So compared to the daytime, everybody tend to have hypoventilation during sleep, particularly if you have any obstructive sleep apnea or central sleep apnea. This will affect the movement of air in and out. So you start to develop hypoventilation based on that. So overnight oximetry is a wonderful tool because it's done at home, and it's pretty easy to do. It's painless and it doesn't cost a lot. The problem is that it measures oxygen levels and it doesn't measure carbon dioxide levels. So if someone has some hypoventilation that starts to present more with high carbon dioxide but less with low oxygen levels, you are going to miss that. So let me give you a couple of information about how an oximeter works. This is a probe. Everybody who comes to a clinic or stay in a hospital for respiratory reason, they know this tool. It's a red light on your skin. And basically the reason that it's red, because it works on the wave of this red color. So it doesn't measure actually your oxygen. It measures the redness of this color. And based on the wavelength, it suggests a number of oxygen saturation based on that. But they are very sensitive, they are very accurate. But you need to know that they are not measuring your blood oxygen, they are just measuring a red color. And they can sometimes fool you. For example, if you have a dark skin, it may not be as accurate. Or if you have uh, a hemoglobin problem, like sickle cell disease, again, it may fool you. It may give you falsely low numbers. The second tool is overnight oxycapnography. You probably don't know this. We have monitors that measures carbon dioxide level from the skin as well. Let me go to this slide because this is the monitor we use here. When you look to these numbers, you see the heart rate, you see the oxygen level, and you see the carbon dioxide level. And the good thing about these monitors is that you set it on the skin. This probe sits on your skin and it records overnight your continuously your carbon dioxide, oxygen, and heart rate. And at the end of the night, we can download and get some numbers. When you think about these numbers, I will tell you a couple of things about the challenges that we have. But the practical challenge with this beautiful monitor is that we don't use it at home. And the only reason is that the insurance don't pay for that. We have the monitor. We can use it in the hospital. We cannot use it at home. This is unfortunately a huge problem, and I have spent so much time to make it happen. There are some states and some providers that make it happen because the companies do it without getting any payment. In Minneapolis, I was more successful. Unfortunately, in Rochester, I couldn't make it happen. But we use these monitors in the hospital all the time. The difference between the oxygen sensor and carbon dioxide sensor is that because the carbon dioxide doesn't change the color of the blood like oxygen, so you cannot rely on the color of the blood. So now this sensor has an electrode in it and it captures the carbon dioxide in the tissue that comes from the capillary vessels and reflects the carbon dioxide level in your blood. And it captures it. After a couple of chemical reactions, it gives an estimate number, which is, again, very accurate, actually. So it's different, and you can imagine that this will take some time, probably 15 seconds, that there's a lag between oxygen and carbon dioxide. So when you look at the same time, you should think about that. It's not exactly on the same time. So I want to tackle a couple of points about measuring oxygen and carbon dioxide and how we diagnose hypoventilation based on that. Because your oxygen, everybody's oxygen stays on certain level during sleep, right? It goes a little bit lower than daytime, but it stays on certain level average. And if it goes lower than that, certain amount of time, this is not normal, so this is hypoventilation. But think about this. There are some individuals that it doesn't go certain level down, it stays up, but there are periods during the sleep that it goes down very significantly. This may be even more harmful than having a little bit low oxygen level in average. So, and there are some times that, this is very hectic and erratic that overnight the average is good, but it goes up and down all the time. And the carbon dioxide, it goes up, but how high, right? It can be a little bit higher than 50, or it can be in 70s. And how long? What is it worse to have high carbon dioxide longer time than short time but very high? Which one should we call hypoventilation? So there are set definitions, but you should understand that it's not that simple. uh, the hypoventilation can present in different ways, and we should be vigilant and we should be proactive in treating this. The third tool is overnight polysomnography, which is a sleep study. During sleep study, we get much more information. We get the two information that I mentioned, the first two tools, but also we can measure the air flow moving in and out through your nose. We can also measure the chest movements, how much your chest is raising, how much your belly is raising, how synchronized they are. And we can also measure other different stuff like heart EKG and sometimes EEG. There are different channels that can be used. The fourth tool is blood gas measurements. So blood gas can be measured from a heel stick or finger stick, which is called capillary blood gas. It can be measured from your artery, which is called arterial blood gas. If you have good, warm fingers, the capillary blood gas reflects your arterial blood gas, which is a pretty painful procedure to do for patients, obviously, also for providers. And venous blood gas, which is easy to get, unfortunately, it doesn't reflect arterial blood gas, and it's not as reliable as arterial or capillary blood gas, unless you have a central venous line. So you should also understand the limitation of blood gas measurements, because it measures only one spot in a time. Uh, However, the overnight measurements are records over the whole night. So think like this. You have an overnight measurements versus someone that in the morning you put a needle in their skin and they wake up, they scream, they take deep breaths, they are anxious, and it will change the blood gas dynamics, the amount of carbon dioxide and oxygen in your blood. So as a summary, this is an important tool, but it's not as reliable as overnight recordings. The last tool is pulmonary function measurements. We can have some measurements reflecting particularly respiratory muscle strength and the lung volumes. How much air can your lungs, we call this vital capacity. The problem with pulmonary function measurements is that you have to have a patient old enough first and cooperative enough. And another problem is that even if they are cooperative and old enough, they may not want to do it, or they may not be able to do it. This requires a lot of coordination. And also another problem is that you can have a leak from your mouth. This will falsely show the numbers smaller than they are. So the first step is overnight oximetry. As I said, we order it in clinic. It's very easy to get the results. But if the overnight oximetry is abnormal, uh, the recommendation is that everybody should get a more detailed uh, monitoring, maybe sleep study or a carbon dioxide measurements overnight. So this is another recommendations is that everybody who have symptoms, clinical symptoms of sleep apnea or hypoventilation, recurrent chest infections, loss of ambulation because of progressive weakness, vital capacity, which is this pulmonary function measurement, less than 60%, or signs of diaphragm weakness, they should get a sleep study at least once a year. And uh, smaller kids with early onset muscle weakness, rigid spine syndrome is another neuromuscular disease, or someone uh, who is having muscle weakness and going to get a surgery, or pregnancy in adults, they need to get a sleep study. So, all right, we do all these studies and we diagnose hypoventilation. So, meaning that your oxygen is a little bit low, or your carbon dioxide is a little bit high, or very high, based on the level of hypoventilation. How do we treat it? And as important, when do we start to treat it? People started to understand hypoventilation early in 20th centuries, particularly during poliomyelitis epidemics. So people were conscious, their brain was functioning very well, but their muscles were so weak that they were not able to maintain uh, breathing. So the chest muscles and diaphragm was the problem here. They developed this iron lungs that was moving the chest with creating negative pressure with a pump. As you see, it's very bulky. The patient has to lie in this machine all the time. It was so hard to have a good quality of life with these machines that served people for many decades. And even some animations used help of these machines, like Superman. They discovered again a tool called pulmotor early in 20th centuries. This was a portable device, as you see, was working with a mask. And like the heart devices that we use these days in restaurants and everywhere, this was sitting in multiple places in the United States, that someone who was stopping breathing while people were using this manual pulmotors, but it was doing exactly the same thing that we are doing today. They were mechanical, but you could add oxygen in them, and they were working with a mask. And it was beautifully designed tools. Today, we call this non-invasive ventilation. We have similar masks, but now they sit most of the time on the nose. It may cover the mouth, we call it oronasal mask, or it may cover the whole face, we call facial mask. We prefer using nasal mask most of the time, because uh, one of the problem with this kind of non-invasive ventilation is it may make you aspirate if you vomit during this. So it's good to have an open mouth that you can vomit from your mouth, instead of vomiting in the mask, that the pressure sends the vomit in your lungs. And this is one of the more modern ventilators that we use. There are multiple beauty of these ventilators, and there's a new model actually coming to the market recently, that came to the market. Uh, the beauty of these ventilators, I think the most important one, is that they sense you taking a breath, starting a breath, then they give you a pressure support. So I think this is very important because in the past, before these ventilators, you should have rated a rate of breath that the machine doesn't care if you are taking a breath or giving a breath. It just gives breaths regularly, or it gives certain amount of pressure continuously, which we call CPAP. So these ventilators, they sense you are starting a breath, and you during you take a breath, it gives us support. So it's a supportive ventilation. It's not a ventilation that we use in a sedated patient in the ICU. This is why this is called non-invasive ventilation. We use the same machines in patients who have tracheostomies, and we call this invasive ventilation. But still, many of the time, patient is triggering a breath. It's not the machine deciding to give a breath. Uh, but in some conditions, if we are not relying on patients triggering a breath, we still put set breaths uh, during the ventilation. So even though the name of the talk, the title of the talk was Respirators, this is the only slide that I'm going to show you related to respirators. But if you have any questions, I'm more than happy to answer them. So unfortunately, we don't have good studies about when and how to start non-invasive ventilation in people who needs them. This is almost the only study done quite some time ago, published in 2005. And they looked for 48 patients with muscular disease, congenital neuromuscular disease, and some chest wall disease. And broad range of age, you see that it's not just pediatrics, but adults. But all of them had low vital capacity, which means they were significantly impaired. So they underwent overnight respiratory monitoring. 26 of them with daytime normocapnia and nocturnal hypercapnia. So their carbon dioxide was high only during sleep. They were randomized to either get non-invasive ventilation or nothing. So you cannot do a study like that today because everybody with high carbon dioxide level during sleep, they need to get non-invasive ventilation. You cannot just leave them alone. But at that time, it wasn't that sure that non-invasive ventilation was beneficial. So they did this study. What they found out is that the patient population who didn't get non-invasive ventilation, they had more morbidities during these 2 years, but also at the end of 2 years, they almost all of them required daytime ventilation as well. So it progressed in 2 years. So there's a international workshop published 5 years ago, 6 years ago now, that summarized that children with congenital muscle disorder resulting in nocturnal hypoventilation or daytime hypercapnia. So nocturnal hypoventilation meaning low oxygen or high carbon dioxide, or high carbon dioxide during the day, they should be on non-invasive ventilation. So this is a statement about congenital muscle disorders, but you can use the same knowledge for any kind of disease in this talk, genetic disorders that would cause muscle weakness and respiratory disorder based on that. So what's the goal of non-invasive ventilation? I think we need to understand this very well. Even sometimes my colleagues don't understand this different level of goals. It's not just correcting numbers. We are not giving insulin to correct a blood sugar number. We are more addressing a clinical picture here. So Patient satisfaction and quality of life is very important. Symptoms improvement, if they have symptoms, and perception of good quality of ventilation. It's so uncomfortable for someone to take halfway breath instead of taking a deep breath. The second one is improving and respecting sleep structure. People many times understand how bad their sleep is, and sometimes they do not, but they suffer consequences of that. The third one is efficacy of ventilatory support. So, uh, daytime carbon dioxide level should be improved. Nocturnal hypoventilation should be improved, and nocturnal oxygen level should be improved. One point that I want to make, I forget to mention about that. You may not know this information. If your oxygen is a little bit lower than it should be, in the long term, it can put a lot of load not on your body and brain and breathing, but also on your heart. We call this pulmonary hypertension. So people who have lower level of oxygen uh, in the long term, they will develop heart failure. So it's an important concept. Lastly, in this slide, we want to start non-invasive ventilation, but non-invasive ventilation itself can cause some problems, like it can induce apnea, it can increase the leaks, unintentional leaks, and also it can cause asynchrony. So the patient and the ventilator doesn't read each other well. So the patient doesn't want to take a breath, the ventilator gives a breath because it's too sensitive, or the patient wants to start a breath, the ventilator doesn't sense it, it's not sensitive enough. Or if you have a lot of leak, again, the ventilator is not going to sense that you are or you want to start a breath. At the end, we want to improve quality of life. We want to reduce respiratory morbidity and also disease-related burden like hospitalization or developing pneumonia and requiring multiple course of IV antibiotics or oral antibiotics. And at the end, and more importantly, improving survival. So we diagnosed hypoventilation. We started to treat hypoventilation with non-invasive ventilation. So how are we going to monitor it? As you saw at the last part of my previous slide here, you can cause some trouble, respiratory trouble, by using non-invasive ventilation. So you have to detect these events and address them. It's not like you get a sleep study, someone decide to give certain pressures, and then you are fine. This is not uh, the reality. The reality is that if you have some discomforts, this needs to be addressed. And these problems typically happens the couple of months following the start of non-invasive ventilation. So the first 3 months, you have to watch a patient closely. Again, the problem in the United States, the insurances mostly don't pay frequent sleep studies. So you cannot have once a month sleep study the first 3 months of your non-invasive ventilation. So this is why people just rely on a sleep study and put some pressures and send patients home. So all the tools that we were using to detect hypoventilation, they should be and they can be used to monitor hypoventilation. So the clinical symptoms, are your symptoms improved after we start non-invasive ventilation, or the quality of ventilation is improved? So these are important. So it's important to follow someone closely. Again, improvement in blood gases. As I mentioned before, blood gases are not the most reliable tools. Overnight oximetry under non-invasive ventilation at home. This is an easy tool that we can use. But again, it's just going to give one aspect of the problem, which is low oxygen. And if it's not impressive before non-invasive ventilation, it's not going to be helpful after you start non-invasive ventilation. The most important tool actually is transcutaneous carbon dioxide from your skin. The Centec monitor that I showed you. It will be great if we could use it at home with non-invasive ventilation, because there are many hospitals who doesn't accept patient with non-invasive ventilation to the regular floor. You need to go to the ICU, which increase stupidly the cost of a simple test enormously for the patient and for the whole system. So many of these new ventilators, they have a SD card in them that we can download and get a lot of information about what's going on overnight. And believe me, we can get an information how much you are using it too. These new ventilators who came to the market now, they even use cloud systems that you can get these downloads on a regular basis in the clinic. And the last one and more detailed one is a sleep study. You see here polygraphy and polysomnography. Unfortunately, in the United States, we do not have polygraphy. And many people don't even know what is polygraphy. Basically, it's a sleep study without surveillance, and it doesn't happen in a sleep lab, but on a regular patient bed. Europe use it a lot because it's much less expensive. We do not have it in the United States for unknown reasons. So this is an algorithm that a friend of mine put together. I just want to share it with you to get a basic understanding how we approach after we start someone on non-invasive ventilation. So the first step is to do an overnight oximetry test and morning blood gas, which is not easy to do at home environment. So this probably would happen in a clinic. So if this is normal, so your overnight oxygen is normal and your blood gas is normal, you should still check your carbon dioxide level. I think this is a very important information. Many people are very comfortable this being normal and everything is normal. It's not the case. You should check the carbon dioxide level. If the carbon dioxide level is normal, then you are fine. If this is abnormal, you should go to the right side of this algorithm. If one of these is abnormal, then you check the ventilator download and check for leaks. This download gives us an understanding about the leaks. Because if the problem is leaks, then you change the mask and you can fix the problem easily. If the problem is not the leak, then you need an overnight sleep study. These are my last few slides. It has been a long day for you, long few days. I know that I am one of the last speakers, so this is why I wanted to keep it a little bit shorter. So this study actually is an important study giving a different layer of information. It's a survey looking for financial burden on families in the United States of children having mechanical ventilation at home. So they looked 226 participants from 32 states from United States, and there were children on invasive ventilation with a trach, 152 children, and 74 children with non-invasive ventilation. So the second part of this slide is striking and so sad, and I know many of you are suffering this problem. So they looked for the last 3 months and the cost from in out-of-pocket expenses on these families. And the number they found is $3,899. It's a crazy amount of money. And when they compared invasive ventilation with non-invasive ventilation, obviously, you can argue that patients with invasive ventilation may be sicker, I am not sure about that. There are centers who use invasive ventilation much more frequent than non-invasive ventilation, like my center here. And the cost in the invasive ventilation, if you even don't include nursing cost, is much higher than non-invasive ventilation, which I think this study is another information supporting the use of non-invasive ventilation. With this slide, I'm going to finish my talk. I am more than happy to answer any questions you have. Also, I want to give you my email, and please feel free to send me an email with any questions you have. And I want to thank you all for making the time of listening my talk. Thank you. All right, I don't see any questions so far. Most likely it was a boring or useless talk, or even if you don't have any questions, I would appreciate any comments for the next time. Maybe next year I will see you in Chicago, and I may prepare a more practical talk if you guys feel it's more beneficial. Um, I My thinking in this talk was that these are concepts that we need to understand together when we think about respiratory problems, because the consequences can't be resolved without understanding the causes and how you develop these problems. Thank you again.